Thanks for inviting. First of all, I do most robotic surgeries, and I'm not against fighting with focal therapy, but today I am against focal therapy, and I am going to explain why I am against focal therapies. The focal therapy, Dr. Rossweiler explained, depends on two things. But the problem is, I think, not with the focal therapy only. The problem is with the prostate. Why? The prostate is its anatomy. It's in a bony pelvis and it's in a very deep structure. It's very hard to image the prostate. It's not like a breast. You put the ultrasound and see the whole tumor around. You can't see the prostate around easily, even with MRI. And the prostate cancer is a very unique tumor. It's a multifocal disease. I am sure that you will remember from your cases, we see this picture very often. You can have multifocal different types of prostate cancers in one prostate specimen. Why do pathologists give us Gleason score sum? Why they don't say well-differentiated prostate carcinoma? Why they don't say poor differentiated? Because the prostate cancer is a unique tumor. It has a well-differentiated tumor inside the same prostate and a pure differentiated tumor. So even it has a very small lesion, like here, with Gleason score 5. Are you going to leave that tissue in that patient? That's the question I have. Another thing why we are against focal therapy, that comes from this study from Dr. Nansen's Journal of Clinical Oncology, very good study. They looked at a prostate gland with a carcinoma. If there are some genetic alterations in BPH tissue, this comes from BPH tissue than normal epithelium. That means if every prostate cancer could be identified and treated locally, focally, the remaining prostate epithelium has already started down a molecular pathway towards the malignant transformation. You will ablate that tissue and you will leave that BPH tissues and they will start. But that's the constant rule. It should be a prostate cancer in that patient. And it's already shown that these BPH nodules have the highest risk of developing prostate cancer. So I think we shouldn't remove that BPH nodules in that patient. How we are going to select the patients? The transrectal ultrasound in some cases 65–70% doesn't detect bilateral disease. So they develop template prostate mapping. Yes, it has high sensitivity, but it requires anesthesia, cost, risk of infection, urinary retention, extensive sampling. After that, if you find multiple disease on biopsies, subsequent radical prostatectomy operation, Dr. Rossweiler knows very well, will be difficult. Please don't forget that. Need to find three-dimensional coordinate to cancer focus. Let's think about MRI. Do you believe that MRI is going to detect prostate cancer tissue less than 5 millimeters? I don't think so. If you identify the index lesion, you will successfully target that lesion with an appropriate ablative therapy, Dr. Rossweiler told. But you identify the lesion with MRI or prostate sampling biopsies, then you ablate the tumor with transrectal ultrasound. There is a disconnect between diagnosis and treatment. Focal therapy depends on index lesions. Let's think about it. But this theory has been challenged. If you leave residual microscopic tumor with high Gleason score, what will happen? And if there is a tertiary Gleason pattern like 4 or 5 in a small focus. And some focal therapists, they said that if you remove the index lesion, bigger tumor, it is not going to metastasize. There are 2 good studies about this. Dubac et al. Identified 12 patients with lymph node metastasis. Only 5 of them showed the same chromosome abnormalities with the index lesion. And Kian reported that chromosomal alterations within the metastatic lesions are identical to non-index lesions. That means metastasis can be made from other tumoral lesions than index lesions. And the other question is, how will you monitor any untreated lesions? What's the nature of history of non-index lesions? We don't know that yet. If you look at the oncological results, do we have enough follow-up on focal therapies? No.
No. I fully agree with you.
Definition of failure is not well established. How we are going to look at PSA? After radical prostatectomy operations, we mostly look at PSA. It gives us variable clues. In focal therapy, a variable amount of prostate tissue remains behind. If there is a residual tumor tissue, the prostate will rise up. And also, progression of BPH tissue will rise up PSA. There is no specific threshold for PSA in focal therapies also. The other question is, what happens if focal therapy fails? I think we should tell our patients that the focal therapy may compromise the functional and oncological outcomes of subsequent treatments, such as radical prostatectomy or radiation therapy. Salvage prostatectomy is extremely hard, especially after HIFU. Dr. Tamahlerin, he told me that he's not going to make any salvage radical prostatectomy after HIFU. He said that it's a disaster. And radiotherapy is not going to work well in necrotic tissues. Because of all of these reasons, EAU accepted focal therapy is experimental. It's still the same like Dr. Dabna, to the best of my knowledge, it's true.
It is true. Yes,
Yeah.
They didn't change yet.
And the focal therapy of prostate cancer is still in infancy and cannot be recommended as a therapeutic alternative. So, I do robotic radical prostatectomy. So, robotic surgery has been developed during the last years. Since 2012, it has been nearly 12 years. Robotic surgery has developed. We have better techniques and better results now. I think it's the most effective minimal invasive technique now. For example, how we can get the trifecta? We can repair the nerves on unilateral or bilateral fashion. If, such as in that patient, if we have, think about it, an index lesion on the left side, we can preserve the nerves on the right side, and we cannot preserve the left side, like in that patient. I don't want to take your card. So, with these techniques, we have better nerve sparings now. We have better results. We have better continence and erectile functions. At the same patient, we can do intrafascial nerve sparing, such as on the right side, you see, and interfascial nerve sparing at the same patient on left side. The second thing is trifecta is continence. The apical dissection is very important. With a good apical dissection, even if in difficult cases, yes, it's important. Yeah. I want to go here. Even in difficult cases, we can achieve good results. For example, in this case, you will see this is the left neurovascular bundle, and this is the right. You will see a BPH node at the apex. Let's go a little bit more. Yeah, at the end. There's a nodule here. We spare the nodule to the prostate side, right neurovascular bundle left, and a very good long urethra. And if you look at the continence rates, it's around 90-95%, some of them are 97%. We have anterior reconstruction and posterior reconstruction in robotic surgery. We applied them and we have better results now. The complication rates are low now after some developments. For example, during the last 2 years we used VLAC and we don't see any more urine leakage in our patients now. So it's a very good development in robotic surgery. last thing, my last talk is about the oncological results. This is Mena's study from British Journal of Urology 2013. He looked at 4,800 very good number, big number patients underwent robotic radical prostatectomy. 8-year biochemical free survival, metastasis-free survival, and cancer-specific survivals are around 90-98%. We have good long-term follow-ups on robotic surgery. Because of these reasons, I think robotic surgery is the most effective minimal invasive technique now. Thank you so much.
I would like to make a comment before, and then I will give the talk to the rest of my colleagues. And it's that when the female lumpectomy, the breast lumpectomy, was for the first described, it was highly criticized. Time has been showing that this is a very good option in not all of them, but in some breast cancers. So after this, are there questions in the room for one or another? Is everything clear? Let me put the last two slides because it's not clear. It's not clear.